Good morning. Good morning. Jeff Newman here, Rome Training. Jeff Newman, Corporate Crazies in an imperfectly perfect world. I have with me once again Dr. Charles Reynolds, Distinguished Professor of Psychiatry Emeritus at the University of Pittsburgh School of Medicine. And currently, Charles serves as editor-in-chief of the American Journal of Geriatric Psychiatry. Uh, may I call you Chip? I always ask permission before I just jump into that.
Yeah, please do, Jeff. Let's keep this informal. I always enjoy our conversations.
Well, thanks for being here again. This is our third get together. Last time, just for the audience, we spoke about internalized stigma and self stigma, and we were welcomed very highly with that interview, that 30 minutes. So let's hope, and I hope for the audience to ask questions, put them in the comments, because what I'm bringing to the table today, because it's a personal lived experience, I want to talk about genetics and bipolar. Reason being, really quick, my dad is a survivor of the Holocaust, 5 concentration camps through his life. I am born, and now I was diagnosed as a person living bipolar and no idea how I received it. But I take it one step further that my 3 young adult children, Jared, Brad, and Amanda, also have lived with a mental health condition. They're stable, they're doing great, but I'm questioning, how did they get it and how did I get it? And then I look at my dad. So the question I want to start off with, and what I've read, uh, that bipolar disorder is about 85% pure genetics, and I get that statistic by a gentleman, Stephen Strakowski, right, Chip?
Strakowski,
Right,
yes,
and
Steve Strakowski.
he's the vice dean of research from the regional medical health at Dell Medical School. So, Chip, how can maybe you start off and incite not only me but the audience on psychiatric disorders and the gene pool?
Yeah, thanks for the question, Jeff, and thanks for sharing your own personal and family experience with me and also with our friends in the audience. You cited the good work of Steve Strakowski. I think it's pretty well established now that there is a strong genetic susceptibility to bipolar disorder. In other words, a strong family history of bipolar disorder. What's also interesting is that various members of a family tree may also have a significant degree of recurring depression. So the mood disorder that we're talking about can express itself in different ways, but that there is a genetic susceptibility is pretty clearly established. And as is the case, I think, with other psychiatric disorders, the genetic susceptibility is the result of more than one gene. In other words, we talk, Jeff, about there being a polygenic risk
Hmm.
for the inheritance of bipolar disorder, meaning that it is ultimately the behavioral expression of more than one gene.
Mm-hmm. Okay. So that makes me think, if bipolar disorder and other mental health conditions, if it's caused by biology, let's say, if that's maybe where it stems from, does the lifestyle of the individual, like myself, whether I lived or I was brought up in an environment, would the environment cause maybe the effects of that condition enhance because of the environment on how you were brought up? Meaning, again, I was brought up middle class, brought up loved, but I was very manic. Okay. And my father was always doing something very in a manic sense. So I guess the question is that because it's biology based, perhaps, is the environment more prevalent as to the effects as people age?
Yeah, Jeff, thank you for the question. Your question gets at a very fundamental issue in psychiatric medicine, and that is the, excuse me, the interaction of genes with the environment. So that's an important aspect of your question, and it's a fundamental focus of considerable research. That is, how does the genetic susceptibility to something like bipolar disorder interact with the environmental context in which someone is growing up to affect the expression of the illness, but not only the expression of the illness, but also some of its outcomes, some of the ways that that illness can respond more or less well to treatment. There's been some very interesting research in this area. I did a bit of a literature review in preparation for our discussion this morning, and I want to mention a specific study that I came across that was led by my colleague, John Kelso, Kelsoe, who's a professor of psychiatry at the University of California at San Diego. John and his colleagues investigated the interaction between genetic susceptibility to bipolar illness, Jeff, and what has come to be called adverse childhood experiences, adverse childhood experiences. The phrase adverse childhood experiences covers a whole bunch of different things. Traditionally, it has meant things like physical or sexual or emotional abuse or neglect during childhood, but has also come to mean other adversities that a child may experience while growing up. Perhaps the child has developed a serious physical illness, for example, like diabetes, or perhaps they've lost a parent at an early age, or perhaps they've been abused or bullied by peers, or have not done well at school. Here's the main finding that John Kelso and his colleagues came up with, and it speaks to your question, Jeff, about the interaction between genes and environment. What John and his colleagues found was that both the genetic susceptibility to bipolar illness and adverse childhood experiences, both of them separately and independently can influence the age of onset, the age at which bipolar illness first declares itself clinically. The other finding, though, that's of great interest, I think, is that the greater the dose, if I could use that expression, Jeff, the greater the dose of adverse childhood experiences in someone who is genetically susceptible to the development of bipolar disorder, the greater that dose of adverse childhood experiences, the more at risk that person is for bad clinical outcomes, such as suicide attempts or the development of psychosis or the development of a co-occurring substance use disorder or other adverse outcomes of that kind. So again, the point that I'm making is that yes, bipolar illness is the product of genetic susceptibility. Your own personal history and the history of your 3 kids is a good example of that. On the other hand, genetic susceptibility can interact with early life experiences in the form of adverse childhood experiences both can influence and bring about an earlier age of onset of bipolar illness. But the dose of adverse childhood experiences, the more difficult the child's upbringing is, the more they are at risk for bad clinical outcomes. And this was the key finding or observation that John Kelso and his colleagues published just last September. This is a relatively new finding, Jeff, which they published in a wonderful journal called Translational Psychiatry. The journal Translational Psychiatry attempts to link basic science with the clinical practice of psychiatry. It attempts to bridge basic and clinical science. I'll stop there to see if you have questions, but this is really a new finding. I find it very credible and very interesting.
Man, I can have you talk forever. Don't stop, but you want to stop so I can rebut and jab you with some thought-provoking questions, which I do have. Okay, so now that you described and we spoke about family genes and maybe how I attracted this, me and maybe millions of other people, I'm going to flip it. And I'm going to talk about awareness. Okay, awareness. The question I have, and I don't put blame on anybody in my life, meaning my parents or my relatives. If, let's say, if mental health was more prevalent back in the 1950s, when I was born, 1958 to be exact. I don't want anybody to think more or less of how old I am. If, let's say, my parents picked up on my being such a great kid, I mean, I was active, I was happy, I always did things, I never stopped. I was always, in quotes, I was manic back at that age, right? That's my manic side. I'm manic right now. If you knew what I'm doing now, I'm 63. I'm doing a lot, and I know that's my manic side. I know that. So if they caught that when I was 5 and they didn't get scared by it, but if they paid attention to it and I received help, whether it be a support group, whether it be a child psychiatrist, just to, not to fix me, but just to make sense as to my way of living, would that maybe help me when I was diagnosed at 52 because I crashed and I lost my entire identity? But if I would have been looked at, just like my dad, he was never diagnosed, never. But I could only imagine the pain he was living his entire life because of his lifestyle, his environment. But if he, at the age of 9, somebody picked up on it because mental illness was prevalent and they studied it and they knew, and he went to maybe to seek some help, would my entire life have been different in a mental state? And I don't know. It's a question.
Jeff, I think you're making two very, very important points, with both of which I agree completely. The first has to do with your statement that you don't blame anyone for your illness. And I think that's a terribly important understanding to have, and that is that bipolar illness is a no-fault illness. Yes, it's genetically mediated, but it's basically a no-fault illness, much as many other medical illnesses are no-fault illnesses. They happen because of genetic susceptibility and because of gene by environment interactions of the sort that you and I talked about a moment ago. The other point that you're making, Jeff, with which I agree, is the importance of early detection of someone living with bipolar disorder. And the reason that that's important is that it allows the possibility of early diagnosis and early treatment, early intervention to quickly stabilize someone and to prevent the downstream complications of living with bipolar disorder. And those complications, as you well know, can be destructive from many perspectives, psychosocial, medical, and otherwise. So again, this has to do with age of onset, and age of onset is associated, as we said before, with genetic susceptibility. And age of onset allows for early treatment and hopefully stabilization at a point when the illness has not progressed to a more difficult to treat stage of illness. I think of psychiatric disorders like bipolar disorder or depression as having different stages, much like cancer, if you will. And the earlier one can intervene, the more likely one is to achieve a good remission and to sustain that remission when the illness is still treatable and reversible, rather than waiting to a later stage when it may be more difficult to treat to a sustainable remission. Let me stop there and ask if my comments are responsive to your question, to your observation.
Yeah, they are, but I picked out one word, and maybe I just need for you to define it if it's ever going to happen. You use the word treatable. Now, when I hear that word, again, I radically accepted that I'm a person who lives bipolar. I personally believe it's not treatable in the sense, I don't mean I cannot stabilize. What treatable means to me is I go through certain steps, strategies through doctors and support groups and my own belief system, and I end bipolar. It's gone. I treated it. I don't have to worry about it anymore. It's gone. You see, my disease is eternal, and I accept that. And personally, I don't want to be treatable because I know I'm always going to have it. So it's almost like a false positive for me to think it's treatable. What I can do is I could be proactive. I could do everything I can to live a loving, joyful, harmonious, fruitful, abundant life and enjoy the fact that I live bipolar, because it doesn't define me and I'm a success either way, but it's never treatable for me. For me. So when you say that, I don't know for me if I could believe that I'm treatable. I am I'm definitely have possibilities to for the best, for the best. But I'll always carry those genetic genes because I've never heard of someone with a mental health condition, even alcoholism. Somebody's clean for 30 years, but they'll always be an alcoholic. They will, because if they went and took one shot, they're going to go right back to where they were. They'll always have it. So I appreciate that. And you did resonate with a lot what you said, but treatable really kicked in. So
Jeff, thank you. I really love the way you're describing this. And again, as with your earlier comment, I'm totally comfortable with what you're saying. I will rephrase what you said a moment ago using a somewhat different language and a somewhat more medically oriented language. We can't cure bipolar disorder. But what we can do is manage bipolar disorder. We can help our patients live with bipolar disorder successfully and manage the risks that can occur with highs and lows of mood and with other downstream complications. I think the other aspect of what you said that I particularly like is the fact that you've achieved a psychological position of acceptance. You've accepted the fact that you're living with bipolar disorder. You've been willing to accept engagement with clinical people like me to manage mood swings and to reduce the risks of downstream complications. And I think that's a very mature and wise position to have assumed. You know, Jeff, in much of medicine, there's very little that we can cure. And what we really are talking about, for the most part, as physicians, unless we're surgeons doing a hip correction or taking out someone's appendix, we're talking about the use of strategies, whether behavioral or medication or otherwise, to manage chronic illness. In other words, to allow someone to have an optimal health-related quality of life, to enjoy life, as you were saying, and to prevent complications. That's the nature of my business as a clinical psychiatrist. Does that make sense?
No, absolutely. I love the way that you, using your term, you redirected it and you use different terminologies, which it's curable. It's curable. And I love that, as opposed to the word, I'm
Yeah.
treated, I'm done.
You and
And
I,
that
you
makes
and
me,
I are saying the same thing. You and
yeah,
I
yeah,
think, are in total agreement. You're expressing, you're describing your experience with admirable honesty. And I'm commenting from my perspective as a clinical psychiatrist, but we're converging on the same point.
no, absolutely, absolutely. It, not to change the subject, but it all goes down to, the language we use
Yes.
in or with mental health conditions. And the only example I have, because I wrote a paper and then I broadcasted it, is about the words we use. Crazy, loony, insane, and I did a whole talk on it. Instead of crazy, why can't we just use the word preposterous? Same word. This is preposterous, as opposed to this is crazy. Because when I hear the word crazy, it triggers me because I'm living that stigma. So yeah, so it's almost the same thing. But we're
Well
winding
said.
down. Yeah, we're winding down to the hour. I just want to say thanks for this. Uh, if, let's say, I'm going to leave, if you, with your permission, your contact information in the post. So if anybody wants to reach out or ask a question, is that okay that they do that?
Yeah, I would welcome that, Jeff. I'm very happy to enter into conversation with you and your network. Folks can reach me through my Gmail address, and you and
Yep.
I communicate via Gmail. That would be just fine.
Okay, fantastic. I'll do that. I'll leave that. Any comments, please put in the comments if they're for me or for Dr. Reynolds, and we will get back with you. I do want to just end this on a positive, and I did this yesterday, last night. I ran the senior strength program for DBSA. We had about 32 people there all over the country, and we go through support. I facilitated it, and I ended the session. I always end with a positive question, and we go around and everybody has about 5 seconds to answer it. It's like rapid fire. It's a lot of fun. The question I asked last night, I'm going to ask it to you, and this is cool, is, Dr. Reynolds, what makes your heart sing? What makes your heart sing?
I have a real sense, Jeff, of gratitude about being alive. Not a day goes by that I don't experience a sense of thankfulness for many blessings. I also, the other thing that I try to be aware of, Jeff, on a day-to-day basis is just the beauty of my surrounds. And I try to practice kindness each day. Those three things: gratitude, beauty, kindness. Those are what make my heart sing.
Mm, I love that. I love that. I hope everyone picks up on that. And I'm going to ask the audience, what makes your heart sing, and put it in the comments. I'd love to read them and then maybe remark. But Chip, thanks so much for this 30 minutes. I learned a lot, and I hope I gave you some thoughts, and we'll do this again on a different subject. And I have a great weekend. And again, thanks for all the support with me and with the community. It's great.
Thanks, Jeff. Be well.
You too. Thanks. See
Take
you
care.
guys.